Acute respiratory distress syndrome, etiology and pathogenesis. Acute respiratory distress syndrome (ARDS) is a diffuse neutrophilic alveolitis caused by a range of conditions and characterized by bilateral radiographic infiltrates and hypoxemia. Activated neutrophils are sequestered into the lungs and capillary permeability is increased, with damage to cells within the alveoli. The pathophysiology is part of the inflammatory spectrum described in sepsis above, and the triggers are similar infective and non infective inflammatory processes. These processes result in exudation and accumulation of protein rich cellular fluid within alveoli and the formation of characteristic hyaline membranes. Local release of cytokines and chemokines by activated macrophages and neutrophils results in progressive recruitment of inflammatory cells. Secondary effects include loss of surfactant and impaired surfactant production. The net effect is alveolar collapse and reduced lung compliance, most marked in dependent regions of the lung, mainly dorsal in supine patients. The affected air spaces become fluid filled and can no longer contribute to ventilation, resulting in hypoxemia due to increased pulmonary shunt and hypercapnia due to inadequate ventilation in some areas of the lung. That is ventilation perfusion mismatch. Now, diagnosis and management. ARDS can be difficult to distinguish from fluid overload or cardiac failure. Classic chest X-ray and CT appearances are shown in figure 10.14 and 10.15 respectively. Occasionally, conditions may present in a similar way to ARDS but respond to alternative treatments. An example of this might be a glucocorticoid responsive interstitial pneumonia. Management of ARDS is supportive, including use of lung protective mechanical ventilation, inducing a negative fluid balance, and treating the underlying cause. Establishing the severity of ARDS is useful, as severe disease will require more proactive management such as prone positioning or extracorporeal membrane oxygenation (ECMO). Now, the box shows Berlin definition of ARDS. Onset within 1 week of a known clinical insult or new or worsening respiratory symptoms. Bilateral opacities on chest X-ray not fully explained by effusions, lobar or lung collapse or nodules. Respiratory failure not fully explained by cardiac failure or fluid overload. Objective assessment, example by echocardiography, must exclude hydrostatic edema if no risk factor is present. Impaired oxygenation. Here figure 10.14 shows chest X-ray in acute respiratory distress syndrome. Here bilateral lung infiltrates, pneumomediastinum, pneumothoracis with bilateral chest drains, surgical emphysema and fractures of the ribs, right clavicle and left scapula. Figure 10.15 shows CT scan of the thorax in a patient with severe ARDS. Note the pathology is mainly in the dorsal dependent parts of the lung. Now, the box shows determining the severity of ARDS. Severity of hypoxemia is calculated using a partial pressure of arterial oxygen FiO2 ratio. This is a number calculated by using the partial pressure of arterial oxygen from an arterial blood gas measurement divided by the fraction of inspired oxygen FiO2 expressed as a fraction. For example, a patient with a partial pressure of arterial oxygen of 10 kilopascal or 75 millimeter mercury on 50% oxygen, that is FiO2 of 0.5, would have a PaFiO2 ratio of 20 kilopascal, 150 millimeter mercury. This would be defined as moderately severe ARDS. If the other Berlin criteria were met, all measurements should be taken on a minimum of 5 cm water of PEEP or CPAP. Mild 40 to 26.6 kilopascal, 300 to 200 millimeter mercury. Moderate 26.6 to 13.3 kilopascal, 200 to 100 millimeter mercury. Severe less than 13.3 kilopascal or less than 100 millimeter mercury.